Hi. Developmental delay is such a common problem in pediatric age group. It can be due to birth asphyxia, it can be due to an inborn error of metabolism, or it can be due to some genetic cause, or it can be due to some cranial malformations. Some are treatable and some are not treatable. But when you identify a treatable cause, it will be very useful for the child to get the neurological recovery as early as possible. And I am Dr. Sharad Balaji on behalf of our group RxTX, and today I am going to discuss about a simple clue that helps to identify the cause for developmental delay. Right? What is this child? So the last week I had seen a child. The child came for 9-month vaccination. You all know that by 9th month we used to give typhoid vaccination as well as MMR vaccination. On examination, on a routine inspection, the mother was holding the child. You all know that by 9th month the child should be able to sit without support, but this child, a 9-month old child weighing around 9 kgs, is not able to sit without support. And there was no head control at all. Head control should be achieved by about the 3 months, but there is no head control. So what is this actually? I was asking the mother what is the problem. The mother said even when we call, the child is not listening to our song. So we don't know what it is, sir. And I know compared to my previous child, first child, a boy, this girl is not able to sit without support by about 9 months of age group. So what is this actually? Let's see. So what is the mystery behind it? Is there any birth asphyxia? No, the child is absolutely normal. Cried at birth and weight of the child at birth is around 3.5 kgs. Is there any neurocutaneous markers? None. Examination did not reveal any neurocutaneous marker. Is there any hearing issues? No. For some sounds, TV sounds, the child is able to look around. But even then, the OAE done at the time of birth was absolutely normal. Head circumference was normal, neither microcephaly or nor macrocephaly. Anthropometry is absolutely fine. So what is this actually? Why the child is not able to sit without support? Is there any inborn errors of metabolism? There are no abnormal urine odor. There is no hepatosplenomegaly. Do I need to do a tandem mass spectroscopy? I really don't know. Is there any neurological issue? Is there any birth asphyxia? Head circumference is normal. AF is anterior fontanelle is appropriate. I don't know whether I need to take an MRI brain. Is there any hearing issue? As I told you already, the OAE taken at the time of birth was absolutely normal. Is it hypothyroidism? Again, the TSH done at the time of birth was normal. Or can it be a case of spinal muscular atrophy or some sort of myopathy? But remember, the reflexes were fine. Do I need to take an EMG or do I need to take a nerve conduction study? Let's see what I have done. But a simple routine clinical examination revealed this finding. So what is this finding actually? Look at this. There is a little bit of knuckle hyperpigmentation that I could see. Really, whether this is knuckle hyperpigmentation or because of the color of the father and mother. The mother is relatively of fair complexion, the father is relatively of fair complexion. So, but this hyperpigmented knuckles made me to look for whether there is an underlying B12 deficiency or not. The mother was ready to take all investigations, MRA, TMS, she was ready. But I want to do one simple test, CBC, to look for macrocytic megaloblastic anemia. So CBC was ordered. So this is in a case of developmental delay with the knuckle hyperpigmentation. We really don't know whether it is a case of B12 deficiency. So let's see. What was the hemoglobin of the child? The hemoglobin of the child is 8.7 grams per deciliter. And what was the RBC? Just look at this, 2.85 million. So RBC number is low, hemoglobin is low. And really now the crux started. What is the MCV? MCV is 98 femtoliters. Is it normal, abnormal, or low or high? Let me tell you what it is. RDW. RDW is 22.8. You all know that RDW somewhere normally somewhere 14 plus or minus 1. Here RDW is definitely high. It was taught that any anemia with a high RDW, unless otherwise proved, must be a nutritional anemia. If it is a microcytic along with high RDW, it can be due to iron deficiency anemia. If the MCV is high along with the high RDW, then it can be due to a B12 or folate deficiency. Then I want to know whether this MCV is high or normal. Let's see. Is there any rule of thumb in pediatrics to find out the MCV without looking into the normograms? The answer is yes. What is a low MCV? Look at this. 70 plus age in years must be the low MCV. This child did not attain even the first birthday. So 70, even if it is first birthday, 70 plus 1, 71. So lower cutoff is 71. What about MCV, high MCV? Again, the rule of thumb. What is the rule of thumb? 84 plus age in years. 84 plus in age in years. So this child, 84 plus 1 must be 85. So low means it should be 71. High means it should be 85. But this child MCV is 98. So definitely it is high. So when I have a high MCV along with the high RDW, invariably I need to think in terms of an B12 deficiency, right? And this child has got neuroregression, which is unlikely to occur in a case of folate deficiency, isolated folate deficiency. So B12 levels was ordered. So look at this. What was the B12 level? Look at this. What was the, look at this. What was the B12 level? The B12 level was 119. What was the normal B12? The normal B12 is somewhere between 187 to 883 picograms per ml. So definitely B12 levels are very, very low. And then when I was asking the mother whether you are a vegetarian, the mother said she was a strict pure vegetarian. She even do not take the milk also. So this is a case of B12 deficiency presenting as developmental delay, and the subtle clue is knuckle hyperpigmentation. So far in the past 15 years, I have around 8 to 10 cases of B12 deficiency identified as a cause for neuroregression within the infantile period itself. Then if you identify that B12 deficiency, either based on methylmalonic acid levels or macrocytic megaloblastic anemia, or when you do a serum B12 level, what is the treatment approach? Here is the treatment approach. So the child should be started on B12. Along with that, you need to give folic acid 5 milligram per day. Along with that, you need to add a maintenance iron therapy. So what about B12 administration? 1 ml of B12 contains 1000 micrograms of B12. So you need to give 0.5 ml IM once daily in the first 1 week. 500 microgram means 1 ml contains 1000 micrograms. So you need to give 0.5 ml intramuscular daily in the first week. Daily in the first week, followed by alternative days in the next week. For example, Monday, Wednesday, Friday. Followed by once in a week for about the next 4 weeks, followed by once in a month for about 4 months. So after that, you need to check whether the B12 levels are going to be low or not, and based on which you need to tailor-made your treatment. So I repeat, 1 ml contains 1000 micrograms. You need to give 0.5 ml daily in the first week, 0.5 ml on alternative days in the second week, and 0.5 ml intramuscular weekly once for the next 4 weeks, and 0.5 ml once monthly for the next 4 months. This is the rule of thumb treatment in B12 deficiency. Okay, particularly when the child is having neuroregression, right? So what is the carry home message in this case? As I told you already, there are so many causes for developmental delay, and one cause for developmental delay or a neuroregression is B12 deficiency, and the subtle manifestation of any case of B12 deficiency in infantile age group is definitely knuckle hyperpigmentation. I hope you will find out this knuckle hyperpigmentation in all cases of developmental delay to look for an underlying B12 deficiency. Thank you.